Welcome to our new edition of the Thyroid International Recommendations Online, our multidisciplinary seminar series that we'll have for the next hour or so. Today's meeting is a fun meeting. We'll do it with our usual panel discussion, but our focus today is going to be on external beam radiation therapy. I think one of the most challenging things we talk about at the tumor boards and some of these complicated cases, and I think we talk about it more than we do it, and we're trying to figure out where do we do it and what's the best way to use it. There are parts of it where it's clearly underused, and it's certainly a key component. And so we're going to try to talk with the panel discussion sort of how do you really do it and how do we decide which cases that would be beneficial. And we'll just have them sort of think through out loud. Let's welcome our panel this morning. There we go. We'll just go around the panelists here and we'll let everybody introduce themselves for about a minute. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center. Let's see, Dr. Liu.
Hi, thanks, Mike. I'm Jerry Liu. I'm the radiation oncologist, manages head and neck cancers for the downtown group at Mount Sinai Health System.
Fantastic, Jerry. Dr. Newbold.
Hi, I am a radiation oncologist in London, UK.
Fantastic. Dr. Ghesani.
Hi, good morning, everyone. Thanks for joining. I'm Munir Ghesani. I'm a radiologist and a nuclear medicine physician, serving as the Chief Medical Officer of United Theranostics and faculty appointments in radiology and neurosurgery at Mount Sinai. I also have a responsibility for running our academic arm, Institute of Nuclear Medicine, serving as the chair. Thank you.
Fantastic. Dr. Brandwein-Weber.
Yes, hi, Margie Brandwein-Weber. I'm Chief of Pathology at Mount Sinai West, and I'm a head and neck pathologist.
Thanks, Margie. Dr. Barrett.
Hey, Tom Barrett. I'm one of the graduating head and neck oncologic and reconstructive surgery fellows at Mount Sinai. Been working with Dr. Urken. I'll be heading as faculty to the University of Rochester in upstate New York this fall.
Oh, fantastic. It'd be great to have you up in Rochester. Dr. Urken, why don't you introduce yourself and then get us rolling?
Yeah, Mark Urken, head and neck. Am I a pathologist, Margie? No. I'm a head and neck surgeon at Mount Sinai, and about to cut the umbilical cord on Dr. Barrett here in precisely 5 days. And as Mike was saying, we really want to focus today on 4 case presentations that are designed to tease out what patients really need external beam radiation therapy. These are the guidelines from the 2025, and if you distill these down, the role of external beam really falls into 2 main categories. The first is when to use it in the adjuvant setting, and this is often where we get into challenging discussions and sort of a gut call that where the surgeon is being asked to make a decision based on whether or not, if that patient were to recur, would you feel comfortable going back in to do another surgery? And then the second part, or the second scenario, is for gross residual or unresectable disease. And the challenge in all of this is that the data, while good, is not in any way supported by randomized controlled trials. And those of us who spend quite a bit of time in the head and neck cancer world, where we use radiation therapy on a very regular basis, understand the toxicities associated with that decision. And the toxicities can be severe when you're radiating in the area of the upper aerodigestive tract. So these are the main differences between 2015 and 2025 with respect to the use of external beam. In 2015, it was recommended not to use it as part of the initial postoperative management, and that has slightly shifted, where, as I mentioned, to use it in high-risk cases, and now to combine it with external beam in those cases where there's a gross residual or unresectable locally advanced disease. So with that as a framework, I think we'll go to the first case here. Tom.
Our first patient presented to Dr. Urken's practice. She was a 7-year-old female with a history of chronic lymphocytic leukemia who had a recurrent oncocytic cell carcinoma. Before presenting to our team here, she was diagnosed with a multinodular goiter in the early 2000s that was observed In 2017, she underwent a thyroid lobectomy for a 4-centimeter nodule. Initially, the path was interpreted as a Hürthle cell adenoma at an outside hospital. In 2021, on a surveillance PET-CT that was performed for her CLL surveillance, she was noted to have an FDG avid lesion in the thyroid isthmus. She underwent a scar excision, isthmusectomy, and an excision of central compartment nodes at Sloan Kettering. Pathology there was consistent with an oncocytic cell carcinoma with 2 foci vascular invasion, involvement of the strap muscles and fibroadipose tissue. Her slides from her initial surgery in 2017 were reviewed. The diagnosis was flipped to oncocytic cell carcinoma. She subsequently underwent a completion thyroidectomy. The right lobe was notable for a foci of carcinoma involving the perithyroidal soft tissue, and she additionally underwent adjuvant RAI. In 2024, she was noted to have a spike in her thyroglobulin, and imaging showed a left paratracheal soft tissue mass, which I'll show on the subsequent slide. FNAs did not confirm carcinoma, but suspicion remained high, and she underwent an excision of the soft tissue mass. So on the left, we see her thyroglobulin trend from at the time point of her adjuvant RAI all the way out to this spike, which prompted the PET-CT, which we see in the top right. We see this FDG avid paratracheal mass. That was FNA, that was non-diagnostic. She underwent a salvage surgery with Dr. Urken. Pathology there was notable for a 4.3 millimeter focus of oncocytic cell carcinoma within soft tissue. Dr. Brandwein, do you have any comments here?
No, you've covered it all. Basically, it was very tiny. It was 4.3, so it's no surprise that you couldn't hit it with an FNA. And really, here it's a contextual diagnosis. In the context where she's already been established as having a Hürthle cell carcinoma, seeing these cells in this soft tissue makes the diagnosis. If we were reading this de novo, let's say this was in the thyroid bed, for instance, it would be a much harder call. And the reason for this is that these Hürthle cells, they look histologically benign. Of course, oncologically they are not, but you don't have the histology to guide you in terms of what the cells look like.
I say, Kate, I don't know who the endocrinologist was working with Dr. Urken on this case, but he must have been out of his mind to think that a thyroglobulin at 27 was going to come from a 4 millimeter nodule. How do you sort of put that together? I mean, is that where the thyroglobulin is coming from? You can see after surgery it dropped down. That just seemed a lot more than I'd anticipated from that.
Yes, I agree. It doesn't seem very reflective of that small, certainly that small nodule. And we would consider wider imaging just to exclude anything distant, specifically with a PET-CT in the context of disease.
Yeah. And Mark, help me understand the decision to go back and take out something that was 4 millimeters. I mean, we watch these a lot. I mean, how are you sort of thinking through that?
So, yeah, I don't remember the endocrinologist that I was working with who will remain nameless there. But part of the challenge in this, which I can't remember necessarily being in a situation to perform a surgery, where this was the first time in this patient for me without a biopsy-proven disease here. And so we were going in with a suspicion, but part of the major challenge was she was just absolutely chock full of lymph nodes that were involved by CLL. And so I did not know how aggressive to be without a biopsy-proven recurrence here.
Right.
Hey, Jerry, we're obviously headed down your pathway here. And there, at least for me, a lot of this decision about using external beam radiation is sort of related to the operative findings and what the surgeon found. And so at this point, what information do you need from the surgeon that kind of helps you make this next step here? Jerry, and then Kate, I'll let you answer that same area. Jerry?
Yeah, thanks. So number one is, how difficult was the surgery? The comment on the slide is it was a very tiny focus within soft tissue. But, obviously we need to speak with the surgeon, see if it's, my goodness, I had to peel it off and piecemeal from the tracheal wall, or it was stuck against a major vessel. And I'm pretty sure I left residuum, even though it might not pick up on a scan. And would a subsequent surgery be unacceptable for the patient? And those are kind of the two top things I think about before recommending adjuvant radiation in this setting.
Yeah, Kate, then Munir. Kate?
Yeah, absolutely. Agree with Jerry. This really is where the multidisciplinary tumor board discussion is critical, because we take a lot of steer from the surgeons who are in that part of the neck and can tell us exactly what they feel about the amount of residual disease and the proximity and involvement of critical structures. And again, as Jerry said, the key is, would further surgery be, removal of pharyngectomy, for example, which obviously we are trying to organ spare at this point.
Gotcha.
Yeah, so this is actually a great case highlighting how functional imaging with PET can often help predict and correlate with the pathology. You mentioned the point about 4.3 millimeter focus, and you see the image on the top right that intensity of uptake is almost the entire left paratracheal distribution, anterior to posterior. So there are two possibilities. One is that the 4.3 millimeter focus is oncocytic, but there are additional cells that are producing and accepting more glucose. Or there's what we call a molecular signal amplification, meaning there's so much glucose there that it blossoms and it looks like it's a couple of centimeters, but the actual focus may be small. That would reflect that the tumor is extremely aggressive as well.
Yeah. So Tom, at Memorial, the language of this was the surgeon happy. And I can't put happy surgeons in my staging systems, and it drives me crazy. So the things I need from you, Tom, is what was the completeness of the resection? And then secondarily, if we recur in this area, do you have a sort of salvage, reasonable surgery that you could do? Do you have a feel for the answer to either one of those, Tom?
I wasn't there for this surgery back in 2024, so I can only glean from the pathology report. I sort of know the punchline to this story, so I know that more surgery is certainly possible here without too much morbidity conferred to the patient.
And Mark, what did you convey to the rest of the team on the drive home after the surgery?
Yeah, so I was not knowing if we were going to find thyroid cancer, suspicious that we would. The question really was intraoperatively, how aggressive should I be once I've identified that elusive focus of disease? And that was really the challenge. And the nerve was spared during this surgery, and certainly being more aggressive, perhaps in hindsight would have been appropriate, but I did not feel by any means that going back in would be problematic. It's never easy, but it wouldn't be problematic here.
Gotcha. Munir, any role for radioactive iodine here?
At this point.
No, so I think knowing that they have not much of the expression of sodium iodide symporters that drives the iodine in them, it would be very limited role. There are some new methods coming up of redifferentiating them, but at this stage, there will not be a role of radioactive iodine.
Okay. Kate, we'll let you do this one. Radiation now based on everything we're hearing, or watch for a bit, see what happens? What do you really do?
Tricky, hence the discussion. We might consider radiotherapy in this situation, but a very focused target volume. She's 70, which sort of reduces my threshold for considering it. But yeah, we may well have considered focused radiotherapy at this point.
Yeah, Jerry, as usual, Kate changed my question there a little bit. So she went from radiation to focal radiation. Can you talk a little bit over it seems like the last 10 or 15 years, your guys' fields have sort of narrowed down. Is that right? Or talk about that a little bit, Jerry.
Yeah, certainly that's right. We're no longer using the massive fields where we cover the entire thyroid bed, central neck, and bilateral necks, as you mentioned before, from jaw down to clavicles. It really should be personalized based on the histology, based on pathology, based on what are your goals of care, and for this patient who's 70, yielding a low, as Kate was saying, a lower threshold for adjuvant radiation. She also has competing risk for death given her CLL and presumably other health issues. So I would agree, a more focal central neck radiation field would be prudent here. Okay. And I think, as you mentioned before, the lateral neck recurrences, Mark could easily take care of those in the future.
Okay. Tom, let's keep going. I think we talked about it and decided to watch for a little bit more, right? Isn't that where we went on this one?
Yep.
Exactly. And so after surgery, her thyroglobulin dropped to 9, but then subsequently increased to about 17. Repeat imaging showed a very similar a mass in a very similar appearing location, as you see in the top right PET CT image. And a soft tissue contrast enhanced CT neck imaging was suggestive of a possibly invasive mass with concern for submucosal extension into the trachea.
All right, Jerry. So now she's growing disease back. We're now growing back over a 6-month period rather than a year. So now we're back into surgery versus radiation. So sort of think out loud. I don't think there's any role for radioactive iodine here or really systemic therapy right now. How are you sort of thinking about surgery versus radiation here, Jerry?
Well, one question is, do you have someone like Mark on your team? So is there an ability in your team to do an adequate resection where you can achieve margins? Where it's acceptable to the patient for their, functional outcome, given their situation. So if you are in a high volume institution with expert surgeons, I do think, surgical resection is reasonable, followed by, at least with a strong intent to offer adjuvant radiation, given this being the second or third recurrence for this patient. But that would also depend on what surgery was and how the patient recovered from surgery.
Perfect. Yeah, and I think just so we can get to the other cases, we ended up having the discussion with the patient back and forth and with Mark. And Mark, how did you finally make that decision to go forward with another surgery here?
Yeah, so surprisingly, and I work with an exocytopathologist, he could not establish a diagnosis prior to surgery based on FNA. And so he came to me saying, I just can't see it. She still has a lot of lymph nodes. Can you please clear all those CLL nodes out so that we can surveil this much better the next go around? So I went in spite of that, after extensive discussion, and went in mission driven that this was going to be her last operation. And so this is what we found intraoperatively. The disease was really extremely adherent to the trachea. I thought it was invading. And so we did a tracheal resection and then what we call a sliding tracheoplasty. This was about a year ago.
And I can go to the histology for the sake of time. Dr. Brandwein?
Sure. So what she had was a multifocal Hürthle cell carcinoma that was in the central compartment, adjacent to prior surgery sites, then also in the left lateral tracheal wall. The largest focus is 1.7 centimeters, but it's really multifocal. It did not extend into the endotracheal lumen. It was about a millimeter away from the tracheal cartilage, and there was the final tracheal margin status was negative.
Perfect. All right, Kate, now we're back to you. So we've got presumably an R0 resection, although none of us believe that because she's got multifocal.
Multifocal, right.
Multifocal. She's got probably other soft tissue mets in the general area. It wasn't like one big gross thing. Radiate now or sit back and watch, see what the thyroid gland does? How do you think through this, Kate?
So again, it's individualized on the patient's fitness, how she recovers from her surgery. It's good news that it's R0 pathologically, although, yes, I take the point about the suspicion of residual disease somewhere. But then I think I might actually watch at this point, but reserve that external beam radiotherapy. Lots of discussions with the patient about expectations here as well.
Absolutely. So that patient part of the discussion, the surgeon, the team. Tom, what happened here?
So post-operatively, from a functional standpoint, she did quite well. Her voice had some mild anticipated defects, but she did not require a tracheostomy and she was tolerating a normal diet. The decision was made with the multi-D team to monitor her with serial thyroid globulins and imaging. And you can see on the top right, her thyroid globulin trend since the time point of surgery, which has remained undetectable with undetectable antibody levels as well. And so, yeah, we're sort of holding on to the option of external beam radiation if anything changes.
Mike,
Yeah, go ahead.
So let me just see if Kate or Jerry here, this focused external beam in a patient who's got what we had to do at that last surgery was to sacrifice the recurrent laryngeal nerve. In a patient with a unilateral nerve paralysis, how focused and how sparing of that contralateral vocal cord can you actually be? I mean, we're talking about really tight fields here. I'd be hard pressed to think that this patient with external beam would be at high risk for needing tracheostomy? Jerry or Kate or both?
Go for it, Jerry.
So I think that it really should be a discussion with the patient, and you want to see you would want to establish the baseline functional component. How are they breathing? How are they swallowing? In this situation, I think it's prudent to be a bit more comprehensive. I wouldn't just treat unilateral around the trachea, especially with the surgery that was done. So I don't think I would be sparing dose to the contralateral cord or nerve. Now, keep in mind that we treat larynx cancer and other head and neck cancers to a very similar dose, and we don't see a high rate of damage to the voice and vocal cords at that dose, 60 gray. So, it's of course concerning given she's lost the function of the left cord. I do think with careful monitoring, we can still have a good functional outcome.
Yeah, absolutely agree. I wouldn't be focusing it to just the hemilarynx or the adjacent level 6 and level 4. I would be coming across midline to otherwise, you don't know what your target is really, and you need to give that margin on the disease to make it the rationale for giving the radiotherapy worthwhile. And likewise with our head and neck practice, we irradiate vocal cords and we don't expect to see particular damage.
Yeah, and not unusual to have to be in the thyroid cancer space. The whole reason we're doing external beam radiation is gross extension, loss of a nerve on one side. So we routinely radiate the central neck. So I worry about it, but I don't remember the last time I saw somebody have a real problem as long as they were looked at carefully like Jerry and the other cord was working well. Okay. All right. That one was a challenging, and I will tell you there was a lot of conversations between Mark and I and two different disease management teams at two different hospitals taking care of this lady. Unfortunately, she was very engaged and very smart and worked through the risk and benefits, which actually helped us a lot in that scenario. All right, Tom, let's do another one.
Sounds good. Our next patient presented to us as a 73-year-old male who had recurrent papillary thyroid carcinoma involving the trachea and cricoid, as well as a biopsy-confirmed scalp metastasis. Before coming to our team, he had undergone a left thyroid lobectomy at a site hospital. The surgeons in that surgery noticed gross tracheal involvement, as well as involvement of the recurrent laryngeal nerve. Pathology there was notable for a high-grade differentiated PTC with a high mitotic rate, multiple peripheral involved margins, extensive vascular invasion and perineural invasion, as well as 2 involved lymph nodes of the 6 sampled. Mutational analysis was positive for KRAS mutant, but negative for BRAF and TERT. At the time, the surgeons elected not to address the intraluminal disease until a completion thyroidectomy was performed to allow assessment for possible RAI. Subsequently,
we got to pause right there because that one just hurts my heart. Dr. Ghesani, the decision to leave gross residual disease behind and clean it up with radioactive iodine. I know you tend to be a fan of radioactive iodine, but can you help me with that discussion there, Munir?
Well, putting my bias aside, I think it is still a very valuable lesson here. And in fact, to your question about the previous case as well, that if you need to make a decision about radioactive iodine, and we know that there are certain cell subtypes that don't have as much avidity, it is very important to establish their baseline avidity by having imaging confirmation before, because once you remove that, you have no idea if they were radioactive iodine avid. And now some tumors have less avidity, but that doesn't mean that every single one of that tumor subtype will have no avidity for iodine. So it's always good to individualize and personalize the treatment plan. And I think this was a very bright idea to keep it in so that we can confirm or exclude the avidity of iodine. That will determine the treatment implications in the future.
Kate, still hurts my heart. Kate, you do radioactive iodine and external beam radiation, both sides of the fence. This decision to leave gross residual behind, knowing that it's there so you can do completion and radioactive iodine, is that a pathway you're down very often?
No.
Yeah, I mean,
and I'd also be concerned with I don't know, Munir, what your thought about having intraluminal disease and then giving iodine. I'd be quite anxious about the possibility of edema whilst the patient is in their isolation room. I'd be worried about that. Is that something you would cover with steroids, or? There
is some data that and I would like Jerry to actually chime in and provide his insight as well, is that the external beam radiation and systemic therapies with either radioiodine or radiopharmaceuticals have a very different cellular biology effect. External beam radiation is generally given in a few seconds, microseconds, or seconds in big photon density, as opposed to iodine or systemic radiopharmaceuticals we use for prostate, neuroendocrine, and other tumors. They have continuous low dose exposure limited by the half-life of the agent that we use. As a result of it, the radiation damage is different. The fibrotic tissue that develops is different. The edema is different. And there are instances where, for example, in a patient where we have thyroid storm and hyperthyroid, we also give radioiodine treatment in hyperthyroid state. And if they have a known toxicosis thyroid storm, we also add a component of a tapering dose of steroids to reduce that effect of edema. So overall, that concern is, of course, there, but I don't think it's as much with radioactive iodine. And of course, sometimes we use the external beam to, in fact, reduce the edema first before we actually administer systemic radiopharmaceutical therapy. Jerry, what do you think?
I don't have much to add other than, the radiation is delivered over the course of minutes. In general, there's maybe a new technology where it is just a few seconds, but that's not ready for prime time yet. And the overall inflammation, given the extent of the intraluminal component, I'd be worried giving external beam without a tracheostomy in this patient.
Yeah. So just for people listening, I mean, when you 73-year-old guy, he's got a biopsy-proven scalp met, he's got gross extrathyroid extension. The histology is not going to be a classic papillary. This is very unlikely one of those classics is going to melt away with radioactive iodine. So you need to be thinking about this as radioactive iodine. Yeah, we may try it as some adjuvant, but it's not going to be primary therapy. Mark, last sentence or so about that sort of operative decision. I mean, I know we're reading notes from the outside, but just for learning purposes, Mark?
Yeah, so, I mean, I totally agree, Mike. And subsequently, this patient did have this was demonstrated to be FDG avid, which is not unexpected. I felt that the best option here was to proceed with surgical resection of this and try to clear his luminal disease and also to excise the scalp. I knew this was not going to be the final word on this gentleman's disease, and but I wanted to get clearance of the central compartment in order to prevent any further airway problems here. Okay,
Tom, take us forward with the imaging, and then let's let Margie look at the path.
Sounds great. So here on the top left, as Dr. Urken mentioned, you can see this FDG avid paratracheal lesion, possibly involving the esophagus there. On the top right, you see the FDG avid scalp metastasis that was biopsy confirmed. In the bottom left, we have a contrast-enhanced T1-weighted fat-suppressed axial MRI image showing the extent of intraluminal disease as well as abutment against the esophagus, which invasion could not be ruled out. I will add he did have an esophagoscopy that did demonstrate no intraluminal extension into the esophagus. And lastly, there's a coronal CT in the bottom right showing the sort of vertical height of this extending from the area of the subglottis down, involving several tracheal rings.
Hey, can you go back for me there? This is a great point. Talk to me about the difference. The last case we were talking about maybe using radiation for little microscopic places that might or might not be there. This is gross residual disease or gross primary disease. Efficacy of radiation in those two sort of settings, it seems like we always bucket them up into those two brackets as we think about it.
Well, we know that thyroid cancers across the board aren't very radiosensitive. We also know from the limited, usually retrospective data that external beam radiotherapy doesn't affect survival in these patients, and we're looking at local control as the benefit. But that is only really mainly with microscopic disease. I think with gross macroscopic disease, you might control it for a period, but you're not going to. You can't guarantee that you're going to get long-standing durable local control. So, yeah, I think we would always tend to go for surgery for macroscopic disease in the first instance, especially here where the function is also likely to be compromised anyway.
So that's the surgical problems. We have to go back to the surgeon and say, we always say everything is resectable, but what's the price you have to pay for the resection? And so, Tom, I assume we headed towards surgery on this one?
We did. The outside surgeons offered a total laryngectomy, which the patient was reasonably questioning about other options. So he was referred to Dr. Urken's practice, very similar surgery to the first patient with a vertical partial cricotracheal resection, a stair-step tracheoplasty for reconstruction, in a local muscle flap, and he required a formalized tracheostomy after his surgery. Dr. Brandwein, I want to comment on the histology here?
Sure. Histology of the high-grade differentiated was established on the original material, and that was based on the mitotic activity, which was 6 mitotic figures per 2 millimeters squared. And as was mentioned, perineural was seen in extensive vascular necrosis, vascular invasion. On our resection specimen, it was a partial tracheal resection, had this residual high-grade differentiated. There's a large intraluminal component, and I'm showing here that you see the tracheal cartilage and the tumor going from the paratracheal tissue into this intraluminal space. Okay.
And Margie, before I take you to the next one,
sure.
So we've got a high grade. We know it was KRAS from before.
Right.
So clinically, is this going to feel more like a follicular with distant mets and vascular invasion, or is that too big?
Right. So KRAS is not the usual RAS in this situation. It's usually NRAS or HRAS. But KRAS is associated with high-grade differentiated. It is associated with an aggressive course. So, it doesn't have the markers, it doesn't have the molecular changes that we usually associate with multifocal vascular invasion, but here we have it anyway.
Gotcha. And show where the high-power views here? Right.
So here we're seeing a tumor which is solid, and you can see it still retains the PTC-like nuclei that are regular, clear, more oval in shape and like very angulated nuclei. Next. Right. And here I'm showing you, how we're going about looking at evaluating the mitotic rate with some of the mitotic figures being circled here.
Gotcha. And Mark, help me understand the surgery, because some of these high grades feel more like follicular. They're sort of encapsulated. They don't have a bunch of gross extrathyroid extension and they come out. Other ones have gross extrathyroid extension. So help me understand the surgery. And what I really want to know is, did you get an R0 resection? That's kind of what I'm after here.
Yeah. So if Tom, if you can just go back quickly to that scan, prior slide. Basically, if you look at the left lower, you'd say there's no way that I could have cleared this and still preserved the function of one vocal cord. His left cord was already out, so that was a non-issue. The importance is at the level of the cricoid, the disease really respected the midline. And so at that point, I did a complete resection circumferential of the tracheal component, but was able to do a hemicricoid resection and then be able to advance the trachea. And so I felt quite good about clearance of this disease, but respected the fact that this gentleman was at high risk for additional systemic.
Right. So the final margin status in the trachea was negative, but it's not something it was negative, but we all expect something to happen in the future, unfortunately.
So Jerry, going into surgery, I would have anticipated this was going to be surgery plus external beam radiation. I'm worried about him getting distant mets because he's already behaving badly. And now you get Mark saying, we got a pretty good resection. I got things pretty clear. What are you thinking now? Watch, radiation? How are you thinking here, Jerry?
I think, again, this is a little bit patient guided. How much do they value? And obviously, I think every patient would value very highly their function of their reconstructed central neck. A subsequent surgery would either be not possible or unacceptable, or would entail a total pharyngectomy, a pharyngectomy. So if the patient wants to be able to accept all the toxicities of radiation, then I think it would be reasonable to treat local regionally, even though the patient already has a distant metastasis. And that's a discussion we can have with patients who present with local and metastatic disease, depending on the extent of Mets. If there's been some time since the most recent systemic workup, obviously that needs to be done quickly before any decision is made.
Yeah, that's one of my favorite tricks. Is a lot of times it's been 3 or 4 or 5 months by the time they've worked through the system, and I get to repeat a PET scan and see if they've blossomed their distant Mets. Kate, what are you thinking about on this one?
Yeah, I too would be expecting to give post-operative radiotherapy, adjuvant radiotherapy, upfront. I mean, as in when we made the decision to go for surgery, and I think you talk to the patient about it as a total package, so that they understand that is likely to happen. And I think even with the excellent negative margins, we would still be considering offering that, assuming there wasn't a significant amount of distant disease. I think even if there was some distant disease, that would I would step back from considering 6 weeks of radiotherapy because of the nature of this disease, which is likely to start going quite rapidly, I would suggest. But I agree with Jerry, if it's slower progressing of slightly less aggressive pathology, then we still consider now local control, even if there's 1 or 2 metastases.
Exactly. Munir?
Yeah, so one word of caution is, given the extent of surgery, if you want to look at the residual disease on FDG PET in this instance, that we should wait for about 2 to 3 months, because it could be quite a bit of post-op remodeling that may cause FDG uptake, and it would confuse the picture. But if you wait for 3 months and if you still see significant residual uptake or increasing degree of uptake, that would imply that there is recurrence of residual disease.
Yep. Mark, then Kate. Mark?
Yeah, quick question for Kate and or Jerry. Do we have the same parameters of packaging adjuvant external beam in a 6-week period the way we do in squamous cell? Do you feel as strongly that as you start getting past 6 weeks, that the benefit of external beam diminishes?
I think you're on mute, Kate.
Jerry, chip in, but I don't think we have that data for thyroid cancers. We do tend to extrapolate that from squames to the high-grade thyroid cancers. And I feel uncomfortable, especially when it's around the airway, of leaving it much longer than that. And my hand went up because I would say to Munir, well, the purpose of our PET scan at that point is not really looking at the local area. It's more to give us inform our decision about radiotherapy by looking at what's more distant.
Yeah, I would agree. However, this is opening a bit of can of worms, like the sequencing of RAI and external beam when we do both. Keep in mind that when we sequence RAI prior to external beam radiotherapy, it's many months before a patient may start external beam and adjuvant. So, they are getting therapy in the interim. But squamous cell carcinoma obviously behaves differently. This is a high-risk area. So while 6 weeks is not really a major concern, I would be I'd be hesitant to give radiation, more than 3 months out.
Yeah, I often repeat the PET scan about 2 months out, accepting that low background stuff in the neck, and I'm looking for something really, really hot focus, right? And so by 2 months, I can usually tell that difference. But good caveat. So what do we do in this one, Tom? How did this patient go?
Catch up here. So post-operatively, he did have a tracheostomy. He's had a palsy of the right core, but that has been regaining function. He's been tolerating an oral diet. Oncologically, we did see that his thyroglobulin level did not go down after surgery, and subsequent imaging demonstrated multiple metastatic sites as well as additional disease in the central neck. 3 months after his surgery, they did an FNA of this paratracheal node, which was consistent with cancer. He had an osseous lesion involving the sacrum, as we can see in the bottom right 2 images on the screen. This core biopsy was consistent with the metastatic PTC. He did undergo an excision of this paratracheal mass with Dr. Urken, and it did confirm that there was thyroid carcinoma both in soft tissue and 1 metastatic lymph node with gross extranodal extension.
All right, Kate at the 30,000-foot view here for me. So we've got local disease back in the neck. We've got distant metastasis. How do you sort of play out radiation, systemic therapy? You play in all of those fields. So help me sort of, how are you going to think through this one, Kate?
So I'll have the patient in front of me. We'll go through what symptoms the patient is experiencing here. But we've now got multifocal progressing disease that is iodine negative, isn't it? So is that right? Iodine refractory.
Yeah,
refractory. Yeah. So at this point, I would be thinking, does he need any symptomatic relief of the bone metastases, in which case we can give some focal palliative radiotherapy, but I would be also working him up to start some systemic therapy.
Exactly right. All right, and there was one question in the comments section from Pinar, Dr. Smith. The question was, how often do you see skin mets without lung or bone mets? Not very often, but it definitely happens, and almost always in high-grade tumors or the oncocyte. And it can be anywhere in the skin. I'm always surprised when I get a call from one of my patients. The dermatologist took this off, and it was thyroid cancer. Yeah. So not uncommon, but Margie, your experience as well there?
Exactly that. If something presents or, soon after the presentation has a skin met, it's going to be usually high-grade differentiated.
Yeah.
And it also carries worse prognosis compared to other sites of disease, right?
It generally does, although you occasionally see one that only has that, and I worry about them for a couple, 3 years. But yeah, it's almost that harbinger of something that's going to be worse. Okay. Alrighty. And so what did you guys really do with this one, Mark? Or we're still in the middle of it right now?
So this patient is being set up to undergo treatment to his bone mets with external beam. I'm reluctant to start systemic therapy under these circumstances, and I'd love to hear from Kate, Mike, what your thoughts are here. What would your trigger be? No evidence of lung disease, 2 foci, hopefully manageable with external beam, given the entire picture here.
I'll go first and let Kate go. My general approach is to prolong their tyrosine kinase inhibitor free interval as long as possible, because we know they only work for a certain amount of time. So as long as I can control things with local surgeries or radiations, I can't do it like every 2 or 3 months, but if I'm buying 3 months, 6 months, 9 months with some localized therapies, I'd prefer to hold it off. There's certainly no role for it in an adjuvant kind of setting. Kate, what do you really do?
Yeah, absolutely. We have limited systemic options, so you have to play the long game and you have to deploy your weapons when they're most effective. And certainly, increasingly, we use locally ablative treatments to hold off that time. So, the other thing with external beam radiotherapy is using stereotactic radiotherapy, where you can get higher doses in. We know that there is evidence from across the varying cancers, but including thyroid cancers, that we can get improved pain control with stereotactic doses over more traditional, conventional palliative fractionations. So, we use that much more. And then if we had oligometastases within soft tissues in the lungs, we also consider radiofrequency ablation, again, just to hold the time when you need to start systemic therapy. And my tripping point into systemic therapy is multi-site disease progression at a significant rate that is either at a significant rate and at a tumor burden that is either causing the patient's symptoms in multiple sites or imminently going to.
Yeah. And Jerry, just for the non-radiation oncologists, most of us think about radiation as like a 6-week course. But a lot of these bone mets, some of my guys will do a single fraction. Sometimes they'll do 3 fractions. We get amazing pain control within days. Mm-hmm. So tell us a little bit about what the patient's going to experience if you have to radiate a bone met as opposed to the 6-week course we're used to.
Yeah, the short course ablative dose radiation therapy can be just remarkably almost pleasant for the patient, especially if they've had radiation before in a more prolonged fashion. You're right. It's either a single fraction, 3 fractions, or if it's a sensitive site, it can be up to 5 fractions. You can do it once a week, twice a week, 3 times a week. It could be really, patient schedule focused. And the pain control, especially with a longer course, the improvement or the decrease in their opiate use, if it's related, can happen right at the end of treatment. And the excellent part with the ablative dose, it's a durable pain control. And, they may have pain from other disease sites, but at that location, that pain control is durable with ablative dose radiation, thankfully.
Yeah. So, absolutely. It's Lance Chung taught me that like 30 years ago. And it's one of my go-to indications for radiating a bone met, right? Pathologic fracture, something big, or pain. And it most of the time when you use it appropriately, they're not even on opioids at all. It works. Cool. All right, let's look at one more case. Let's look at this third case, an unusual case that's aggressive, and let's get partway through this. All right, Tom?
Sure. Thank you. This next patient presented as a 33-year-old female. who initially noted a thyroid mass in 2020. At that time, it was an FNA was performed of this 5.1 centimeter nodule, but the cytology was consistent with Bethesda 2. She noted interval growth, decided to pursue surgery a couple of years later. As part of her preoperative workup, she had a chest X-ray as well as a chest CT, and both showed concerning multifocal pulmonary nodules suspicious for metastatic disease. Underwent a PET CT that was suggestive of an additional metastatic disease site to her lumbar spine, as well as redemonstrating these bilateral lung nodules. She eventually underwent a total thyroidectomy with Dr. Urken in January 2025. Pathology demonstrated this PTC, a follicular infiltrated variant that was 6.5 centimeters and well encapsulated multiple foci.
Right.
And I'll show it on the next slide as well, the histology, and with mutations as T and EZH1.
Right, here we go. Well, we often talk about tumors that are born bad or large tumors which become bad if they're not treated, in a timely fashion. And so this was unfortunately quite a large tumor, apparently not treated in a timely fashion, which was 6.5 centimeters. You could see that it is PTC. It has this, what we describe as a paraganglia-like pattern. In some places, you don't see it here, where you have the solid nesting pattern. That's a pattern that anecdotally has been associated with the former RET PTC, formerly named RET PTC mutation, but she had no evidence of that. Is that correct?
Correct.
I think so, right?
Yes.
Correct.
So basically, she had multifocal invasion, but no ETE and only one focus of vascular invasion. So the metastatic presentation did not quite jive with the primary tumor, but for the fact that it was really quite large. And in the end, we submitted the entire tumor. There was no necrosis. There was no extensive vascular invasion. The mitotic hotspot reached 4 mitoses per 20, which does not quite rise to the level of high-grade differentiated, which would be 5. So she's a high risk based on her distant metastases, and you could figure that she was on her way to becoming high-grade differentiated.
Yep. All right, keep going, Tom.
So after surgery, she underwent an radioactive iodine scan, and her lung nodules and stapler lesion were found to be elevated. She received 350 millicurie of radioactive iodine in March of last year. On the top right, you can see her thyroglobulin trend before surgery, or it was 3,700 roughly, with a decrease to 390, and subsequent administration of RAI and a decrease there to 45 by the summer of last year. On her subsequent imaging, the lung nodules responded favorably, as well as the lumbar spine lesion, although there was not complete resolution of that spinal lesion.
Yeah, go back for me. Munir, weigh in here a little bit. You guys must have done this, so she probably had dosimetry. So talk a little bit about how you give 350, and then talk a little bit about the efficacy of radioactive iodine in these bone mets.
Yeah, so we actually did a 4-time point pre-therapy dosimetry on her using a low dose of radioactive iodine. And what we found was that the intensity of uptake of iodine was quite high. And the other thing that combined with it was that she's young, no comorbidities. Her bone marrow reserve was excellent, and her renal function is excellent. So in fact, we also did a post-therapy dosimetry, and when we compared the doses to the lungs, so when you give a high dose of radioactive iodine, the 2 organs that are rate limiting are the lungs and bone marrow. And in both of those instances, our predicted delivery was less than 20% of the threshold. And in fact, when we did the post-therapy dosimetry, it turned out that it was about 15% was delivered. So even the prediction was higher than what we actually delivered to individual sites. And in fact, when we did the post-therapy scan, about 9 months later, all of the lung nodules had resolved. The neck had still residual uptake, that disappeared as well. The L4 lesion on the right had decreased iodine uptake quite significantly, but there was still residual uptake. And as you can see from the graph, the thyroglobulin did not bottom out. So we knew that there was viable residual disease at L4. Everything else responded to treatment.
Yeah, so that's what we did. We see lung lesions, particularly in the RAI avid ones, respond nicely, like in kids and these 30-year-olds. Margie, she had a TSH receptor and an EZH1 receptor mutation. Some of those have been described in hot nodules, kind of adenomas. Would that make us think it's more likely to concentrate radioactive iodine, or am I just making stuff up?
Well, maybe you're asking the wrong person. I would ask Dr. Ghesani about that one.
Yeah. So, I mean, but a lot of times they can be a little bit more RAI avid. Kate, you do both radioactive iodine and external beam radiation. Are we eventually going to have to radiate this bone met? You got a great response in lungs. Let me ask you two questions. One, does she get another dose of radioactive iodine and when? And then secondarily, my bias, I don't think radioactive iodine cleans out bone mets, and I'd be leaning toward radiation to that bone met. But what are you sort of thinking there, Kate?
Yeah, she's had a fantastic response to radioactive iodine. So the temptation is to go in with more iodine at that point. But now we've got just one metastasis remaining active, or we think, then I think that is a situation where some focused stereotactic radiotherapy would give a very good, hopefully ablative response in that metastasis. And then you can hold the iodine for if there's sort of further progression systemically down the line.
And Jerry, how are you thinking here? I assume this is asymptomatic in this lady. It doesn't look like it's something that's about to fracture. Do we just give radioactive iodine more time and there's room for more radioactive iodine? Do you radiate? How do you sort of think through this with Munir?
Given the overall response, where this is essentially now the only site of active disease, it's a great opportunity to ablate and prevent the functional decline of a pathologic fracture or pain. So it's more preventative as well as local control. So I think ablative radiation therapy at this point is actually prudent.
And Munir, help me in terms of timing of the next dose. I think when you and I first started this, we were retreating folks at 6 months and 6 months and 6 months. And now it seems like we watch the thyroid globulins, they nadir around 18 months, and we reevaluate. So how are you sort of thinking in an RAI avid patient like this? She's not cured. She's still got a thyroid globulin of 45. How do you sort of think about when you're going to do that next administered activity, Munir?
Yeah, so I think our paradigm is shifting here. We're not in any kind of rush to continue to deliver it in a short burst of 6 months. And also, I agree with Jerry and Kate that we have turned this was a widespread metastasis into oligometastatic disease. It's a great opportunity to deliver the preemptive external beam radiation to prevent any pathologic fractures and put the iodine delivery as on the back burner in the future whenever there is a need, hopefully not, but if there is another site or multiple sites of metastatic disease, that would be when the next cycle of radioactive iodine would be more appropriate.
Yeah, because I think we've realized very unlikely to be curative, right? So we're not going to cure this likely with radioactive iodine. It's going to be palliative. And if it's palliative and the only thing we have is some low-level thyroid globulins, sitting back and watch. And often in these, when they do start to grow back, you see that thyroid globulin go up for a year, 18 months, 2 years before you see the structural change. Right. So there's a window there to retreat. Mark, we're about to finish up. Last questions or comments on this case or big picture here, Mark?
Yeah, two big questions here, or one for Jerry. Jerry, what would external beam to this area look like for her? And then maybe a question for the panel in terms of what to anticipate in this patient, given her presentation. What do we expect will actually happen here? Jerry?
Right. So this can be done anywhere between 1 to 3 fractions. The lesion, at least the FGG portion of it, doesn't seem to be abutting or even encroaching on the spinal canal. So I think you can get a really good dose in there. In terms of side effect from treatment, there may be a little bit of edema that may blossom some pain, which could be easily managed with over-the-counter or even steroids if necessary. But overall, I think it would be a low toxicity profile from the treatment with durable local control and prevention of decline, which would be great.
Yeah, and in terms of prognosis, this one's really hard because of the bone met. If this was just the 33-year-old with the lung met,
right,
prognosis would be this thyroid globulin would just gradually go down over 20 years, and she may never need another treatment.
Right.
You don't see many 33-year-olds with bone mets, right? So that's the hard part. This tumor was so RAI avid, there's a good likelihood that you killed some other microscopic bone mets or you prevented them from happening. So I think her progress is going to be far better than an RAI refractory with the bone met. But I tell these guys, if you've got a patient with one bone met, you just haven't followed them long enough, you will eventually find another one. But I suspect her natural history here is you're not going to have to do anything for 10, 15, 20 years if that TG stays the way it is and nothing dramatically changes. So I'd be optimistic from her. Kate or Munir, I'm almost running out of time. Thoughts in terms of prognosis, outcomes, any different there?
Yeah, I agree with you that it's single lesion that is still active. Potentially all micrometastatic lesions may have been treated. So hopefully this will stay at a very low grade of FDG and iodine uptake, and we won't have to give her another cycle for years to come.
Right, because we're used to this setting in RAI refractory or mixed RAI refractory, right? We just don't see this very often in the RAI avid, which is good. I thank you, panel, for a wonderful discussion, I think, helping us think through these issues. Keep going, TIRO that you know about. We've got a couple of upcoming meetings, Voices of Wisdom. Listen to those on the podcast. They are terrific. We have a special session July the 10th coming up. That's going to be Ask the Professors. There will be some opportunities to send in questions beforehand. So we're going to try to take some questions we didn't get to in the last sessions and other questions we all get and just have a group of panelists sort of think through these practical aspects. And then we'll be back with the tumor board on the 17th from the team from Brazil. And then JP Brito and Dr. Forsch on the 24th. All right, next one. Fantastic. Thanks for tuning in. Thanks for a wonderful panel discussion. Great challenging cases. Thanks, team. Thanks, Tom. Bye-bye.